Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. Hello and welcome to another episode of the Sleep is My Waking Passion podcast. I am your host, Dr. Alison Kole. And today I'm going to be talking about insomnia. I'm going to be talking about having OSA and insomnia, a condition called COMISA. And I'm going to be talking about what we can do about it. What's the best evidence and how the folks at Wink Sleep are bringing it into the latest century with some digital stuff they are testing. So this is Dr. Chelsea Reynolds. She is a PhD and a clinical psychologist and researcher at Wink Sleep. You can get more information about her at winksleep.com. She knows Alex Sweetman, who I've had on the show before, who has talked about COMISA, so please check that out. He was in an earlier season. Welcome, Chelsea. It's so wonderful to have you.
Thank you for having me. I'm excited to talk about it.
So, guys, just so you're aware, Chelsea is in Australia. I'm obviously on the East Coast in the United States. And what makes this cool is I'm here. It's 7 o'clock. I'm caffeinating, and she is winding down because it's 8:30 p.m. her time. So we're both working some crazy times to make this happen, to give you this education. So seriously, Chelsea, I super, super appreciate this. So just in terms of insomnia and COMISA, can you distinguish for the listeners what the difference between the two is and why is it clinically meaningful? Why do we care about the difference?
Maybe I'll start by defining insomnia to start with, because COMISA is essentially insomnia plus sleep apnea. So I'll do them a bit separately. So for someone to be diagnosed with insomnia, they need to have had difficulties falling asleep, staying asleep, or waking up too early in the morning for at least 3 nights of the week for at least 3 months. That doesn't necessarily mean that, it's always that short or that long. Some people have acute insomnia, which only lasts a few months. And some people that I treat in clinic, it's chronic insomnia that lasts for many decades. And all of us have experienced tricky night's sleep. So I'm sure most of your listeners can relate to what that must be like to have chronic insomnia for that many years. When we talk about COMISA, this is all of those same things, all of the things that make insomnia what it is, as well as sleep apnea. So with sleep apnea, we have people who have a relaxing of their airway muscles so that their air is cut off a bit, and they will experience desaturations in their oxygen. Essentially, they're having pauses in breath all night long. And this means that they wake up feeling extremely tired. They wish that they could just keep sleeping. But it can also mean that people, especially when they're aware of their sleep apnea, they're waking across the night as well. And so when we talk about comorbid insomnia and sleep apnea or COMISA, it means that they have those insomnia symptoms very much alongside their sleep apnea. And that can be really hard to deal with because sleep apnea is kind of a medical thing that we work with, and insomnia is a lot more of a psychological thing that we work with. It's often debated, which one do you treat first? And they're clearly both equal issues for a lot of people. So what we're doing with our program, Bedtime Window, that my colleague Alex Sweetman, you spoke about, he really babied the project. He created it from the ground up. And then myself and Celie Richardson, another clinical psychologist, we've also come on board. And the three of us are really working to help treat insomnia and COMISA using our digital insomnia treatment program, digital CBT-I.
So my understanding, and I learned this from Alex, and I do believe that he talks about the fact that when you have COMISA, when you have both sleep apnea and insomnia, it's sort of like the way I summarize it is sort of double whammy in terms of the health effects or the health impacts, meaning it's not great to have the both of them because particularly when it comes to risk of death, or what we refer to in research as mortality risk, there's a substantial increase in mortality when you combine the two disorders together. I was just wondering if you wanted to highlight some of those health effects that you feel that by being aggressive about managing, particularly the insomnia, we're going to reduce those health effects by improving sleep.
Yeah, absolutely. So it sounds like you and perhaps your listeners who are longtime fans will understand about the mortality for COMISA, but particularly that sleep apnea risk. So there are long-term medical risks for someone with sleep apnea when it comes to heart health and longevity and mortality. We also have the compounding mental health risks that go along with insomnia. There can be often comorbid depression and anxiety. And so when you experience COMISA, you are at risk of having both of those things happening for you. So it can be a really tricky time, but also, as you said, can be long-term health effects for someone in that situation. So it's not fun. And it does mean that we want to treat it as soon as possible to mitigate those risks for that person.
Yes. And can you explain a bit to my listeners exactly what you mean by cognitive behavioral therapy and for insomnia, the standard CBT-I, how it's being used now? Because then I want to get into the digital and the differences.
Yeah, absolutely. So CBT on its own, cognitive behavioral therapy, is therapy that is used in lots of different modalities. So CBT-I is just for insomnia. There is CBT all on its own, which we often use for treating depression and anxiety and other mental health issues. And there's also other versions like CBT-I for eating disorders, for example. So it's a gold standard treatment, and then lots of people have worked on top of it to specify it for different disorders. So if I break it down a bit, the C of the CBT, cognitive, means that we're working on people's thought processes. We work in the understanding that someone's thoughts influence their behaviors, and then their behaviors can influence their emotions. And then those emotions in turn influence their thoughts. And it goes around in this kind of potentially negative cycle, definitely a negative cycle for people with mental health issues. That's where the behavioral part of the CBT comes in as well. So in order to help someone, overcome negative cycles of rumination, for example, and some behaviors that are maybe maladaptive and not helping them to improve their mental health, then we're tackling it with cognitive strategies and cognitive techniques, but also behavioral ones. I could probably go on about it a lot if I were to talk about how we use it for depression and anxiety, but I imagine you probably want to figure out how we use it for insomnia.
I would love to know that. Yes.
Yes. When we talk about CBT for insomnia, CBT-I, we're working specifically on cognitions surrounding sleep. So for some people, a lot of people that I work with insomnia, the maladaptive thoughts that they just can't help but fall into the pattern of thinking are things like, I'll never get a good night's sleep. Things like, I have to get 8 hours of sleep, otherwise I won't feel good tomorrow. Things like, if I don't take a sleeping pill, I'll never sleep well. So those are some thoughts that it's very valid that they think that way because they've experienced such difficult sleep for so long. But it becomes a bit of a negative cycle. And then the behaviors that might go along with that, if I don't get 8 hours of sleep, then I won't feel good. Then they find themselves being in bed for, say, 10 hours. And they think, well, I'm in bed for 10 straight hours. I might just happen to get 8 hours of sleep. So I should just be in bed as long as possible. And what they're doing, lying in the dark, is more or less torturing themselves. There's no way that their body's going to sleep for 10 hours. And so they have these cognitions going around and around and around. And so some of the cognitive techniques we could use would be to talk to them about those beliefs, investigate, maybe use some behavioral experiments as well. This is where the C and the B go hand in hand, to find out if those beliefs are true. Like, do you really need 8 hours? Sometimes do you feel actually okay on only 7 or sometimes maybe 6? The more behavioral strategies, which I could have led with because I often do in clinic, we use techniques like sleep restriction therapy, sleep compression therapy, bedtime restriction therapy, all different terms for essentially a similar technique, which is just be in bed for as long as you're asleep. So for a person who's only sleeping for, say, 6 hours, but they're in bed lying awake for an 8.5 hour period, I'd say, well, don't be in bed for 8.5 hours. That just sounds like torture. That's 2.5 hours where you're really not going to fall asleep. So just be in bed for 6 hours, for example. And that in turn teaches them, I actually don't need to be in bed for 8 hours. Maybe I actually don't need 8 hours of sleep. Maybe 6 is okay. Maybe we bring it back out 6.5 hours. And then by then learning things to their behaviors, they're treating their cognitions as well. And this is often quite quick. I find that when I arrange someone's sleeping schedules in a way that makes them so sleepy, like only to be in bed for 6 hours sounds awful. And people are usually very sleepy. But it does work quickly because the sleepier the better when we work through these therapies. And so we often do see fairly good techniques. And this is the kind of thing that we like to put together in our digital program as well.
What is the difference between the digital platform that you guys have been working on versus a traditional CBT-I model in terms of, obviously digital just means you're doing it all online, but is there just even a different approach to how you're doing the digital versus standard CBT-I?
Yeah, so when we work with people in person, obviously, there's lots of different techniques we might use out of order, and we might tailor things specific to that person. And you develop a relationship with someone, and it's very much a therapeutic alliance. But we're essentially using the same evidence-based techniques as we do on the digital platform. And so digitally, most often it is self-guided, and that's what our program does. We allow people to work their way through the program. It's a 5-session program, and they will be entering different bits of information, getting different bits of sleep education from us. So the education they get has been designed by Alex and Celia and I to be the most evidence-based and what we believe to be the most efficacious when it comes to treating insomnia. And they get that kind of when they can. So it's really handy because people might not always be able to get in to see a therapist in person. They might not have any near them at all. They might not have the money as well. Like, it can be expensive to see a psychologist. And the digital platform kind of allows for those barriers to not be an issue. And so as much as it's self-guided, it's also incredibly handy. And from what we can see from our results, they're getting the benefits as very close to what they would get in face-to-face therapy.
Yes. Speaking of which, what I love about what you're doing at Wink Sleep is you really are creating evidence as you go. So you are building something that's self-sustainable in terms of offering services that people who are interested in have insomnia can go to, but it's being done in a way where you're really trying to gather data along the way. And you should be so, so proud of that. It's amazing. Can you talk about the data for insomnia for digital CBT-I that was published in 2024? And we can go ahead and have a link to that. But there is going to be a manuscript up and coming that has just been verified too. And it's digital CBT-I for COMISA. Did I summarize that correctly?
Yes.
Awesome.
Yeah.
So what did you find? What were like the key highlights that you want people to take away from this talk? We'll start first with using the digital platform you discussed for insomnia.
Yeah. So I guess I should probably clarify with the clinic of Wink Sleep. It's where I do my private therapy. And then separately to that is the work that we do on the digital program Bedtime Windows. So just to be clear, they're both really great organizations, but they are separate. And then with Alex and Celia and I, we're working with the Bedtime Window program. We often feed things in back and forth with each other, which is really, really cool that we can have that working for people. So with the digital insomnia, are you hoping that I can talk through the results from those studies that we published?
I think if there are key highlighted results that you want to showcase, that would be the plan. So whatever you feel comfortable with sharing. I don't want to make you feel like you're like, okay, I have to have exactly these data points. I don't want that to be the case so much as when people listen to podcasts, they're mostly just wanting to pick up on okay, what did they find? And what makes this kind of sexy and relevant to the topic of sleep?
Yeah, absolutely. So when we first started the program, we designed it so that we were testing our treatment through trials. So that means that we got just a small-ish amount of people. So our first trial had about 62 people in it. And this was to test the most effective parts of the program. And then from then on, we expanded. So the first study that we published in 2024 was looking at adults with just insomnia. What we did in this first trial was just to test pure insomnia on its own, so not with COMISA. And when we got the 62 adults with insomnia, we split them into two different groups. So the first group, we randomized them. So one of the groups got the insomnia program, digital CBT-I, bedtime window, and they had that 5-session program, which was to guide them through all the different modules that we put together and to have their sleep improve through different. And then the other group, we called it a control group. So this means that they were not doing the active treatment, but we gave them some sleep education information. So it's a control because they were getting some sleep information online in a digital format. So we made it as close to the program without being the actual program as possible. And then when we compared after 2 months, so after 8 weeks of the groups doing the two different things, we found that the people who did the program, they had lower insomnia severity scores. So we measured this through questionnaire information. We take it at the start of the program and then we test it throughout. And there was quite a good difference there. So it means that for some people, they went from having significant insomnia to not having what would be considered, diagnosable insomnia at all. They also had some positive results in their depression symptoms, their fatigue, and also in some of those maladaptive beliefs about sleep. So like I was saying before, some people are really, really attached to some tricky beliefs about sleep that are not helping them necessarily. And those beliefs started to decrease as well. So they were repairing their own tricky cognitions about insomnia as they went through it.
So in terms of the sleep education piece, was there a difference in other words, did the sleep education arm also improve just to a lesser extent? I'm very curious about that.
Yeah, that's a really good question. They often do improve just a little bit. And we've seen this through a lot of our trials. So they measure a bit of improvement because they are getting something, like they're getting something that they haven't had before. And they're also being given a bit of hope that they know that they're going to get the program at the end of it. That doesn't mean they're in the active treatment, but we do often see that they have some slight improvements. However, that's not near to the extent that the participants having the active treatment got. So that is really helpful because then we can see, okay, when they're both doing similar things, they're both helpful in some way, but the treatment that we're actually giving them in the program on top of that is giving them benefits. And that's where we get our evidence base that we're not just being nice to people online, we're actually giving them things that truly change their sleeping patterns and their health.
Wow, that's so cool. So can you highlight for us, if it sounds like you may have taken the similar approach to a COMISA population, would that be fair? Or is it a little bit, or there's some nuances to the testing?
No, so we didn't change anything about the program when we included people with COMISA. And part of that is because we want to create a program that is accessible to everybody. So we're testing it in people with just pure insomnia or insomnia symptoms, I should say. We're testing it in people who have diagnosed sleep apnea, and we're testing it in people who have suspected sleep apnea. So they might have not gotten a diagnosis yet, but from our questionnaire analysis, we're seeing that they may end up with a diagnosis given on what they're reporting. We're also testing it in people who are on sleeping pills as well. This is data that's not yet published. It's very much still under analysis, but we're hoping to present it at a conference later in the year. And so we want to make sure that it's accessible and appropriate for everybody, but we obviously have to test that first to make sure that we know that the people who we're including in this study, it's appropriate for them. So when it comes to the COMISA population, so the people who we examined, was it effective for those who have sleep apnea? We found that very much, yes, the same effects were seen whether they had sleep apnea or not, and that it was an improvement that was lasting beyond the 8 weeks. So we still tested them by questionnaire data up until 24 weeks after the program, and they'll have seen some really, really great improvements in their sleep.
I remember when I first learned about COMISA, and I was blown away when I spoke to Alex because I really had this bias that I didn't recognize that I had, simply because there was no literature to kind of get me out of my bias. But the bias really was, how the heck am I going to get someone with bad sleep apnea to actually go through cognitive behavioral therapy? I've definitely had the experience of treating obstructive sleep apnea and then having the insomnia go away. And I know the literature estimates that probably about a quarter to a third of patients, that will be the case. You tackle the OSA, the insomnia sort of resolves itself. In my clinical experience, when people have their sleep disrupted a lot during the night, but they're generally able to fall asleep and they happen to be tired, I tend to notice, I'm going to fix that sleep disruption. They're going to sleep better through the night. I'm probably going to get success. That's the way I go. They also typically have pretty bad sleep apnea. So we're looking moderate to severe, anything that's going to really increase your cardiovascular risk in and of itself. So I tend to lean toward treatment first. But I'm curious because I know Alex was saying, well, the data actually suggests that you should do the insomnia piece first. So now I know that always the standard recommendation, and he actually said this, I remember on the podcast, was, listen, it's got to be an individualized approach. But I was curious as to, since I spoke with him last, if there's any data that supports if you see a certain a pattern, this might portend. Again, it doesn't have to be, a p-value level significant, but this may portend that this person really should be doing insomnia right out of the gate versus getting their sleep apnea treated, or conversely, vice versa. I mean, I have my clinical opinion, but anything to substantiate based on the larger volume of patients that you guys have seen with COMISA?
Yeah, God, that's such a good question. I know that there are studies who have looked at phenotyping when it comes to treating insomnia, so essentially breaking it down to what works for different people. I don't have any data in front of me. In our research that we've been doing, we haven't necessarily looked at sleep apnea outcomes in the people who have COMISA. We would love to. I think that's going to be part of a future study that we do, because you're right, sometimes it can be helpful to look at insomnia first, and other times it can be helpful to look at sleep apnea first, and sometimes both. In our population, like in the study that we're testing, people will be on CPAP, for example, while going through it and still getting similar results. I know from clinic, and again, like you have similar, just anecdotal opinions from your clinical work. It can depend, but I do find that with sleep apnea, as you know, it's really vitally important that they have some sort of treatment, right? Because we know that they have long-term health risks if it goes untreated. But that doesn't mean that they're actually going to be okay using a CPAP machine. It means, they know it's helpful, but that doesn't mean that they can tolerate it. And part of that for people with COMISA is that they're just lying awake, hating it. And then their insomnia is getting worse and worse. And then their sleep apnea is getting worse as well, because they're not getting sleep and they're not really using the CPAP appropriately. So I would, from my professional opinion, like to treat the insomnia kind of first, but maybe slightly in tandem with working with a physician such as yourself, so that we can work on some of those maladaptive beliefs they may have, maybe even using some gentle sleep restriction therapy to help them consolidate their sleep, so that if the CPAP's really bothering them in the night, they're just so sleepy they fall back to sleep, and then they can try to consolidate their sleep over time and kind of treat both at once. But I do think that if their treatment adherence is really, impaired by some insomnia that's underlying, then we're probably not going to get far with CPAP unless we treat their insomnia first.
I have one final question for you, and it is a little off the beaten path, but I'm hoping that since you have this big clinical psychology background that you can help me out. A friend of mine has been really curious about having a program related to ACT therapy, acceptance commitment therapy, particularly for patients who tend to have a lot of anxiety issues related to their sleep. And I was wondering if you could explain that a little bit and how that therapy might be used adjunctively with insomnia. Again, it's not really based on your data points, but I have you, so why not ask? I'm treating someone who is working in tandem with the psychologist specifically on ACT therapy, and I'm assisting in terms of kind of making recommendations for slowly starting to restrict sleep. This particular individual has difficulty with large swings, so we've had to be very gentle and sort of do a very personalized approach, one that we would be more aggressive in if you were doing a standard cognitive behavioral therapy model. So it's quasi that.
but I have become fascinated with this and would love for you to talk a little bit about that and maybe your experience with using it as an adjunctive tool in insomnia.
I love this question because I have been increasing my own use of ACT kind of techniques in my clinical work with people with insomnia. So this is very timely. So this works out really well. So when I think about acceptance and commitment therapy, there's a lot to it. It can be used in lots of different ways. Essentially, we are hoping that we can help someone to defuse themselves from their negative experiences and negative thoughts that they might be having. What this means is that for some people, the thoughts, if I make it relevant for sleep, the thoughts of, I'll never be able to get to sleep, that in itself can make them feel incredibly discouraged. And then it increases their fight or flight response. They're lying in bed in the dark, not doing anything, but their heart rate's going really quickly. And it's because they've just become so caught up in this pattern and this habit of thinking. And so what ACT tries to do is to detach them from that and to say, look, this might just be a tricky night and I probably will survive. And that acceptance part of the ACT is really working on those cognitions in a way that helps them to just be okay with it. And that it doesn't necessarily mean it's not going to get better. But it also comes back to just don't try so hard to fall asleep. Just don't try so hard to fight against these negative thoughts because that's not working for you. And so what can we do that gives you permission, I guess, to not have to worry about things in this way in the middle of the night? So when I do ACT therapies with people, it could involve things like, very gently saying back to their brain, it's a bit abstract for a lot of people, but saying back to your brain, that's okay, I'm not going to deal with that thought right now. So it doesn't really fit with what I want out of tonight. And so I'm not judging that thought and I'm not going to be really angry at that thought, but I'm just going to put it aside and maybe fill my brain with something nice instead. And that in itself is really tricky. I've got lots of ideas that I give clients, but trying to, I guess, give the brain permission to stop that kind of hamster wheel of negative thinking.
I think, though, that so many people who are going to feel really anxious with sleep, in other words, they're trying to go to bed, because I've been in this position, trying to go to bed, and then you're suddenly you become anxious about all sorts of random stuff that may normally have been anxiety provoking during the day, but you just have either not had the time or not allowed yourself the time to kind of manage those. Is that the kind of thought pattern that you also address with ACT in these sessions? My point being that I get being anxious about sleep in general, like what you're describing, but I also think there's going to be an awful lot of people where that anxiety that's keeping them up is really not stemming necessarily from anxiety about sleep in the classical sense. Yes, they eventually kind of train themselves to see the bedroom as being bad and very sympathetic nervous system activating, so they can't relax to go to sleep. But does it help with those anxious thoughts that are sleep adjacent, like just are actually contributing to the fact that you can't sleep because now your mind's racing, be it about work or whatever's going on in your life that's really stressing you?
Yeah, I think that really comes into it. So for a lot of people, the insomnia can kind of start with negative life events. So whether you have a really stressful time at work or really stressful interpersonal experience, those are the thoughts that keep you up, of course. It's not necessarily, oh, now I'm not sleeping, what's going on? It starts with thinking about the things that have gone wrong. And then that turns into thinking about the next day and planning ahead. We like to worry in the future. It doesn't really help us, but we do it anyway. And then over time, as you said, that turns into that association of, no, I'm not sleeping. And then if I'm not sleeping, then I'm not going to feel great tomorrow. And I'm going to feel even worse about the situation I'm in that's been on my mind. And it becomes a kind of cycle like that. I like your point about how we're anxious in the day. And then as soon as our head hits the pillow, we can't distract ourselves. And I often think about how in the daytime, it's really easy to be distracted and to just keep kind of pushing through. Whereas at nighttime, it's completely dark and it's completely silent. And your brain has nothing better to do than tell you about all the things you did wrong that day or all the worries you might have for the next day. And so I do also give people permission to try to avoid those thoughts. I don't condone avoidance necessarily as a psychologist, but the middle of the night is not the time to be analyzing and problem solving. Like it's your middle of the night brain is not going to be the most realistic and rational and functional and helpful. Sometimes it is, but it's really rare. Usually when you wake up in the morning, you reflect and you think, oh, that was silly. That was obviously never going to work. And so I like to help people come up with strategies like what you said, the video you saw of Michael's, the cognitive refocusing, working on what can you fill your brain with that is neutral to positive and something to turn the mind to when your brain starts to have that habit of negative thinking. So I've had success with people thinking of like favorite TV shows or books or movies and trying to come up with different endings to those. A lot of people connect really well with like nostalgia. So thinking about childhood memories, like positive ones, places they've been when they were a kid, or even their favorite childhood books, because it's fairly low mental effort, but it's also positive, and hopefully they can just kind of bring their mind back to those kinds of things when they start to enter rumination. Like just give the mind permission to not have to think about the negative thoughts right now. And I only really do this in tandem with CBT-I because, like I said, if someone is in bed for 10 hours and they're only going to sleep for 6, 7, 8 hours, then that's the problem, like no amount of act is going to fix that for them. They're just in bed for too long. It's simple as that. And it's literally maths. It's just be in bed as long as you're actually sleeping. And so I do that as well. But that's not also an immediate fix. I need to give them something to do while their body's still getting used to consolidating their sleep and the sleep pressure. So it's really cool that we can have all these different techniques in tandem so that we can help people, through the first few weeks of sleep therapy and hopefully that becomes a lasting technique for them as well.
And the cognitive refocusing, one of the things I love about the messaging around that is that it is really a behavior that you could practice during the day, right? Nobody's expecting you to suddenly come up with this whole approach to how you're going to think about a situation that may give you anxiety. And now you're trying to do that like right before bed and figure it out. Not good. You got to practice at least during the day. That also segues into another really important point that I like to share with my patients often, which is what you do during the day really does impact your night. So, using your day in a way that will allow you to be able to surrender to sleep. Again, maybe it is saying, man, I'm really stressed about this. Let me just sit, understand that I am, understand it's a feeling, and think about how I might use a tool like cognitive refocusing. What would be my favorite thought when this happens so that I know I can eventually get to sleep. So kudos to you and your team for all the work you are doing. And thank you so much for joining me tonight. Do you want to leave anyone with any final words? Where can they find more information? When do you think you're going to have a digital CBT-I platform ready to go? Is that something that is already available?
We would love to have it freely available. At the moment, we do have a lot of people joining our study through our research trials. So what we have is a study, what we call in primary care, so with GPs, and they are currently referring in patients into us to use the program. And if they meet our screening criteria, then they get it for free. So that's really, really cool. So in that trial, we have over 300 GPs who referred over 1,200 patients to us. And so the people who've been screened in are freely accessing it now. We do have a website. It's a bedtimewindow.com, I believe. I can probably give you that in the link. But if you search bedtime window, you'll find it on Google. And from there, people can get in touch with Alex and myself and Celie to see if there are any research trials going on that they might be able to access. I should say at the moment we have our ethics approval for Australian people doing these research trials with us. But that doesn't mean that we're not keen to broaden our horizons in the future. And
what you're really doing great work and making it easier to understand cognitive behavioral therapy, because I remember when I first kind of graduated fellowship and you feel almost awkward trying to explain even what it is. You're like, it's a number of things, but it will help you sleep, and it's sort of such an unsatisfying answer. And now having transitioned to having the time to talk to folks like you and really get into the weeds of understanding things on a deeper level, I'm like, oh, okay, it's not as complicated as my brain made it seem when I read about it in the ASM guidelines for therapy, and they just list it all out in a chart, and it doesn't feel as tangible and as actionable as it really is.
Yeah, it is a slippery construct, I think, but it really works. So
it does.
Trust in the process.
Well, I'm going to let you go. Please have a wonderful evening, and I'm going to get the kids off to school shortly.
Enjoy.
Take care. Bye-bye.
See you, baby.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.